Okay. Hi, everyone. My name's Natalie. Thank you all for being here and for your continued interest in Global Grand Rounds. As a friendly reminder, you are able to receive CME credits for being here, and I will put the link in the chat box. Today's presentation is by Dr. Muhammad Gill, an assistant professor of internal medicine at Western University of Health Sciences and an internal medicine physician currently practicing hospital medicine in Northern California. Dr. Gill, is there anything you'd like to add?
That's good. Thank you.
Okay. Go ahead and begin.
Hello, everybody. Good morning and welcome to Grand Rounds. I have put together a few series of lectures. This is one of the lecture of the series, and try to make it interactive and less boring as possible. And today's topic is very well familiar by all of you, most of you, and so there were some updates and practice guidelines. As we know that every few years, a Diabetic Association and United States Task Force come up with some preventive care updates as well. So I try to put that all together so we can have sort of a refresher in diabetes. So as we know, diabetes mellitus, it's a disease of a poor metabolism of glucose, manifest by mal-secretion of insulin, and that affects metabolism of tissues and macrovascular complications. Today we will discuss diabetes type 2, and we'll start sort of follow a case study, not case study, but a patient, and we'll follow the care of the patient, how we see in actual clinical scenarios. So let's begin. Natalie, please, let's start with the first slide. Okay, so we have a 42-year-old African-American gentleman with history of hypertension. Dog presents to the clinic. He has a strong family history of diabetes from both sides. Request that please screen me for diabetes. Do I have diabetes? Take the detailed history, family history, socioeconomic history. We do all his symptoms, review, positive and negative, and then we examine him. His blood pressure is in normal range, and vitals are stable. Physical exam is okay. He's taking amlodipine. However, BMI is 33. So you will go ahead and do 2 fasting plasma glucose. The first one is 128, the second is 130. That's the criteria by ADA, the diagnosis of 126 of fasting plasma glucose on 2 different occasions. Therefore, we established diagnosis of type 2 diabetes mellitus, and patient is sent to diabetes educator for lifestyle changes and diabetes mellitus teaching. Next slide. Now, patient has initiated diet and exercise as advised by diabetes educator. Patient comes back in 2 to 3 months follow-up. He's still doing 150 minutes a week exercise, and he's following the consistent carbohydrate diet. Blood pressure is now 142 to 82. The log of glucose showed that fasting glucose is running somewhere 80 to 90 range, with postprandial glucose are 100, 120. A1C is normal to 5.5. So which means that this is working for him. However, blood pressure is high. Next slide. So what do we do? So on first diagnosis of type 2 diabetes mellitus, it is recommended that we do atherosclerotic cardiovascular disease assessment. And this is done in conjunction with American Heart Association and College of Cardiology as a primary prevention, and also advised by the US Task Force. The assessment for the atherosclerotic cardiovascular disease is done in 4 major areas: coronary heart disease, cardiovascular, which is essentially the coronary ischemic heart disease, then cardiovascular disease, and peripheral artery disease, thoracic and abdominal aorta, either aneurysm or atherosclerotic disease. The assessment basically involves all these 4 different areas. And keeping in mind that ischemic heart disease is one of the major causes of mortality in the United States. Next slide, please. The risk factors for atherosclerotic cardiovascular disease, premature family history, which means that the death due to coronary artery disease at age 55 among males means father, and 65 years of age if mother or first degree siblings had the death due to coronary heart disease. And that is obtained through history. Also, cigarette smoking, when we took the history initially, hyperlipidemia, LDL, HDL, these are the labs that should be done on first when we diagnosed this gentleman with type 2 diabetes. He does have hypertension, CKD, diabetes mellitus, high BMI. And so atherosclerotic heart disease assessment starts at age 20, if any of the risks are present, and then 4 to 6 years. If there are none of these risk factors are present and patient does have type 2 or type 1 diabetes, we don't need to do the risk assessment. We go, next slide, please. We do the quick chart. These are the values needed during history and exam, and some of the laboratory data. After putting in the data, we do the 10-year risk assessment. The severity is usually 15% or more. And if that happens, next slide, please. That happens, which means that the primary prevention for ischemic heart disease or atherosclerotic heart disease should be done. And that's a totally different domain. If you go into detail, that's more like the ischemic heart disease and cardiovascular disease topic. Without going into too much detail, I get detract. What is important from diabetes and endocrine side, that anytime there is more than 15% of risk of atherosclerotic heart disease on ASCVD risk calculation, it is recommended to start patient on high intensity statins. If it is a moderate risk, moderate intensity statins should be initiated. I hope that you guys have the handouts and you can magnify this. Are you able to magnify the chart, Natalie? Let's see. Okay, that's okay. So basically, if you see the top box, I can quickly go over it. The top box is the risk factors, and it says hypertension, diabetes, cigarette smoking, family history of cardiovascular disease, high cholesterol, chronic kidney disease, obesity, and lipid, and check the lipid profile. So there's essentially one lab that needs to be done for the calculation of ASCVD risks for 10 years. And so LDL, if it's more than 190, and then look for familial hypercholesterolemia or genetic disorder through history, and otherwise we go towards the age-based. So that's the next step. If LDL more than 190 or 190, go to age-based risk calculation, 20 to 39, 40 to 75, and more than 75 years of age. Most patients fall in the category of 40 to 75, where when we calculate the risk, if it is intermediate to high risk, we initiate primary prevention strategies, which is statin, as I said, aspirin, lifestyle changes, which means the exercise, losing weight, and going down on BMI, target less than 30 BMI. And if it is not achieved, even bariatric surgery is also recommended. Next slide. So as we talked about, fasting plasma glucose equal or above 126 milligram per deciliter. The first step is diet, exercise, reducing the SCVD risk factors. Screen for complication for patients, the sending to optometrist and the podiatrist for ulcer screening and urine albumin. Target A1C is less than 7. That should be a target. If we compare the A1C level, the equivalent plasma glucose is usually around 150 or more. So therefore, what we want to keep it is under 150, and roughly that would be our A1C level of 7. Ketosis high and a very high A1C. At that point, the patient, even though it's type 2 diabetes, must be screened for must have a need for insulin use. So we'll talk about GLP-1 agonists. These are newer medications with new updates. So if we fail the step, so there is one number 3 months follow-up. Just remember that. In managing type 2 diabetes in clinic, 2 to 3 months follow-up after making a big change is usually recommended. So you ask the patient to come back in 3 months after you have initiated the primary prevention for ASCVD, if after risk calculation, and have patient do lifestyle modification as Hello, are we still there?
You're all good. You can continue.
Okay. All right. I'm sorry about that. Next slide, please. I love this diagram. I stole that from one lecture a long time ago. If you look at the diagram, it will tell us the defect of homeostasis and what medications would help correct that or help with that defect of glucose metabolism. So starting from the pancreas on the left side, impaired insulin secretion. When type 2 diabetes mellitus is first diagnosed, half of the beta cells are gone. That's based on our scientific knowledge. So impaired insulin secretion is the cause of type 2 diabetes mellitus, and medications that can help with that are listed below the problem. The sulfonylureas, the meglutide, GLP-1 agonists, and DPP-4 inhibitors, they all help with impaired secretion, means these medicines increase the secretion of insulin from primary source. Neurotransmitter dysfunction, GLP, which is glucose-like peptide secreted from endothelium of intestines, amylin, bromocriptine. These are different medications that affect these neurotransmitter dysfunction. Basically, they are sort of agonists. Increase lipolysis and reduce glucose uptake by adipose tissue happens in diabetes, and thiazolidine diones are the medicines that it will improve, decrease lipolysis and reduce the and increase the glucose uptake. So essentially, therefore, thiazolidine dione medicines cause weight gain and not liked by most patients. Increased glucose reabsorption, and that happens in diabetes. As well, SGLT2 inhibitors prevent that. Muscle uptake, where metformin and this medication occur, and then increase intestinal reabsorption. Very important function is gluconeogenesis during diabetes. That function goes up, and metformin and other medicines bring it down. And the last, but not actually the least, but increased glucagon secretion, GLP-1 receptors agonists prevent that to basically cut that function down. So all these impurities lead to hyperglycemia, and intervention lead to bringing, these interventions bring down high glucose level. Next slide, please. So hyperglycemia leads to spike postprandial, and which cause acute toxicity and ketosis or diabetic ketoacidosis. Essentially, a calculation mostly common ketosis is in type 1 diabetes, which is we are not discussing during this discussion. The chronic toxicity that is measured by hemoglobin A1C levels. Diabetes complication, we all know, macrovascular myocardial infarction, stroke, peripheral vascular disease, and microvascular retinopathy, neuropathy, and nephropathy. And therefore, for the macrovascular, we do SCVD, risk calculation. And for microvascular complications, make sure that we send patient for regular screening for the diabetes-related complications. Next slide, please. So these are general tips: initial, dilated, and comprehensive eye exam shortly after diagnosis, and should be repeated annually. Similarly, annual foot exam for foot ulcers, and microfilament testing for neuropathy, annual tests for urine albumin excretion, usually mostly type 1, but also type 2 diabetes. And that signifies if kidneys are under attack, and that gives us a good understanding where we stand as far as kidney functions. So next slide, please. Okay, 6 months later, our patient comes back. We do A1C, it's 7.9. He's under a lot of stress, lost his job, and however, he says that he's following his diet and doing exercise. BMI is 32. BN creatinine is 28.6. And we do complete metabolic profile. We start patient on now metformin therapy as he has failed lifestyle, and 500 milligram twice a day. Over 2 to 4 weeks, we adjust according to his postprandial glucose level and fasting plasma glucose levels. The log he keeps given through a diabetes education. The patient wants to know about side effects. Important things. Next slide, please. When we talk about oral hypoglycemics, important questions to remember are whether this causes hypoglycemia. Is it a weight neutral, weight reducing, or weight gaining medicine? what to do when renal failure, how do we monitor is through A1C, how do they work, and the cost. Actually, I should say cost at the top. Metformin inhibits gluconeogenesis, increase muscle glucose uptake. I refer to the diagram or the picture that I shared earlier. The UKPD has protection from a macrovascular diabetic complication in overweight patients. So this metformin has proven to reduce macrovascular complications and therefore ASCVD risk. Metformin is a weight neutral drug, however, proven to have a reduction in some patients, weight reduction, contraindicated with only if eGFR is less than 30 ml. So this is an update. Some of our physicians still remember the creatinine of 1.4 and 1.3 among females and males, and that's not the case anymore. If patient is on metformin and kidney functions have deteriorated a little bit, so now we are calculating eGFR. If it's still more than 30 and metformin is working well for patients and creatinine is worsening, and let's say it's 1.8 now, however, patient does not show signs of hypoglycemia, ketosis, we continue that. However, if the eGFR before initiating metformin is less than 45, we do not initiate. Similarly, eGFR falls below 45 in patient already taking metformin, we calculate benefits and risk. And around contrast, we have a 24-hour period before and 48-hour after iodine-based contrast use. So then the excretion is what we expect it to be. Next slide. So we explained all that to the patient, that this is a good option for you to start. Patient is started, he comes back in 3 months. A1C is still at 7.2. Fasting plasma glucose is 100 and 120, postprandial is 160, 170. Now we offer him to add another agent. And he wants to lose weight. As we can see that his BMI is still high. And what would be the next best option? Now, glipizide, which is sulfonylureas, thiazolidine, they also gain weight with fluid retention, one of the mechanisms. So there are 2 or 3 new possibilities, relatively, not new, but relatively. GLP-1 receptor, well, GLP-1 agonist, SGL2. I think this F is probably a mistake, or DD4. Now, GLP-1 agonist is currently being discussed, and the options are semaglutide, exenatide, different medicines, very highly desired, who can afford, and lots of physicians like to use it these days. It's hot in the talks. Next slide, please. So once we explain the patient, that this is the best option to go, it's a weight reducing, the patient says, well, it's expensive and insurance doesn't cover it. So he chose glipizide, and patient asked questions about DPP-4. These sitagliptin, DPP-4 is a weight neutral drug as well. The DPP-4 is actually well tolerated, and decreases A1C as well. the DPP-4 option is also proven to reduce ASCVD risk. So it has cardiac friendly profile. The third agent is SGL2, which prevents the reabsorption of glucose from nephrons. And the other options are sulfonylureas, TZD. So now we have these few agents which are most commonly used. The decision should be made to cater needs of the patient, the cost, and one very important factor, that's weight reduction and weight gain. So after doing cost benefits, talking to the patient, one of the agent should be added to metformin as a second medicine, and see what the follow-up says. Next slide, please. Okay, this slide is about DPP and SGLP, GLP-1, I apologize. We just talked about it, so the mechanism of action for GLP-1 and GIP. These GLP is a glucose-like peptide, and GIP is glucose-dependent insulinotrope peptide. They are gut hormones, and they're secreted from intestine, and they help regulate insulin secretion. So once we discover GLP-1, it is found to be very well tolerated, help with natural mechanism of its glucose absorption and metabolism, and therefore it also help with the weight reduction. The GLP-1 agonist works at, if you look at the slide after GI tract, when gut hormones incretins, and GLP-1 agonists help with these incretins to have a agonist effect, or increases the insulin, and essentially regulate the insulin metabolism at the level of muscles, and also prevents the gluconeogenesis. The DPP-4 enzyme, that's also a normal gut hormone, gut enzyme that breaks down GLP-1 and makes it inactive. With these enzymes inhibitors, basically you're increasing the incretin level, and therefore increasing the insulin sensitivity, secretion, uptake, prevent gluconeogenesis, and eventually reduction in blood sugar level. Next slide, please. 3 months after initiation of double agent, patient's A1C is went up, and postprandial glucose 200 to 280. Now you want to start patient on basal insulin, because now after, so this now is the time that patient should be started on insulin, and this is the criteria. Right after failing 2 agents and A1C more than 9, and postprandial glucose level is high, or if there is ketosis. So basal bolus regimen of insulin glargine 15 units is started, and pre-meal insulin aspart as well as started to control the patient's plasma glucose. However, after a few days or few weeks, patient is admitted to, it's a hypothetical situation. I actually put together a few cases, sort of make it our understanding that how do we follow these patients and change the management. So patient is admitted to the hospital with atypical chest pain. The cardiac cath is clean. You are called to evaluate the patient in the hospital for brittle glycemic control. Next slide, please. So choosing a second diabetic agent. This few algorithm I added to the slides will help us navigate with confidence. When do we actually choose a second diabetic agent? So, for example, after metformin, when it was failed. So what do? We just look at the very easy algorithm. This patient, after having metformin, still has A1C more than 9. And if eGFR is more than 15, let's screen patient for polyuria, weight loss, polydipsia. And if patient is still having all of these, we will initiate insulin, calculate ASCVD, heart failure, diabetic kidney disease. If patient is not, so if not in polyuria or polydipsia, because these essentially are saying that patient is probably going to go into ketosis. If we look at the next level where it says, does patient have polyuria, polydipsia, weight loss? Now that's a severe hyperglycemia, signs of severe hyperglycemia, which means at that time we need to initiate insulin in type 2 diabetes. If not, patient does not have polyuria, polydipsia, not losing weight in that regard, no signs of ketosis. However, A1C is still above 9, eGFR is above 15. It's time to look into the second agent. We discussed GLP-1 and other agents based on patient's need, hypoglycemia profile, weight loss profile, and cost effectiveness. Next slide, please. How do we initiate insulin? This is a rough estimate. We usually start with 0.2 units per kg. We start with the basal insulin first, monitor the patient, keep the log, and then we add the, if still failing after 2 to 3 months, we will add the insulin pre-meal and monitor A1C level after every 2 to 3 months. Next slide, please. So you are called to evaluate the patient in the hospital for brittle glycemic control. You find that the prior insulin regimen has been discontinued by the admitting hospitalist. So now the patient has been placed on a sliding scale insulin with regular insulin pre-meal. What do we do? 2 options: keep the same regimen of regular insulin pre-meal based on the sliding scale, or we change it to fast-acting pre-meal Lispro plus long-acting insulin glargine. The option number 2 is correct, and that's advice from the ADA. Next slide, please. So ADA consensus statement, for the majority of insulin use, the pre-meal target should be less than 140, and random less than 180 is acceptable, which means that this is a safe window where tissue toxicity is, a possibility of tissue toxicity is much less. The scheduled basal bolus insulin is preferred. Prolonged treatment with sliding scale insulin alone is discouraged. And non-insulin antihyperglycemic agents not appropriate in most hospital patients. So like metformin, glyburide, which is common medicine, and other oral hypoglycemics, we should avoid them because patients in the hospital, we have a better control. There are surgeries or other acute issues are happening, patient going into stressors, like either has pneumonia or acute phase reactions, which essentially prevents and actually complicate the metformin-like agents present while this patient is going through all this. Therefore, insulin is the best course for a patient who is hospitalized. Next slide, please. If patients are critically ill, the hyperglycemia associated with increased mortality among critical ill patients, and several professional societies have therefore recommended tight blood glucose control. So patients with stroke or any significant acute illnesses are requiring ICU admissions. It is acceptable to have insulin drip even in non-DKA patients. And several studies have actually showed the benefit of doing intensive glycemic control, unless there is a contraindication. IV insulin is the best way to maintain target glucose with safety measures. Next slide, please. There was a study done called Nice Sugar. The target was 90-day all-cause mortality. And they found out, the study is actually published in New England Journal of Medicine in 2009. And what they found that the intensive glucose control of 81 to 108 and conventional control means if patient was critically ill, admitted to ICU, when the target of 81 to 108 was the best, had shown best outcome. The best 90-day all-cause mortality was low if we kept the target between 81 to 108, and patient on in regular med surg or regular floors, non-ICU patients, keeping the target of less than 180 was good enough. The 90-day all-cause mortality was low. This was a large trial. They have more than 6,000 critically ill patients registered. So it's a pretty good study to refer to when it comes to hospitalized patients' diabetes management. And I think with that, next slide, I think we have done. Questions, comments, please.
Thank you, Dr. Gill. That was wonderful. Yeah, we'll open the floor for questions, and I'll resend the CME form.
Oh, hi, Dr. Gill. I have a quick question for you.
Yeah.
Can you hear
please.
me? Yeah. So, first of all, I want to thank you for giving such a wonderful presentation. So my question is, with the advancement of, all the blood testing devices nowadays, that things that allow you to check patient to measure, and track the blood glucose level and the A1C level. I want to ask, would it be possible for physicians to manage diabetic patients, with control blood sugar solely through, remote care or telehealth? Or do you think that the patient still has to, the patient should still occasionally, go and visit the clinic to see the doctors in person?
Yeah, I mean, good question. In diabetes is a very complex disease, and I think if it comes down just for the blood sugar level monitoring, telehealth might be a quick follow-up, acceptable for a quick follow-up. However, if we are going into detail of blood pressure check, calculation of BMI, and we might need patient to be physically visiting the clinic or have means of doing all this calculation. Actually, home devices can check blood pressure as well and BMI too. So it's quite possible actually to just do the follow-ups from home. I personally do not run a clinic. I'm actually transitioning right now. I'm planning to do hybrid care. So that will be, that's a good question for me, how I will get into the field. But I think, yes, it's possible, especially with many good devices out there to measure peripheral plasma glucose level. And most patients, including my parents, they do their own blood sugar. My mom does her own blood sugar check, blood pressure. We have device at home. And so, however, for complications and doing the eye exam, foot exam, it will require patient to go in person.
Mohammed, a question. Can you hear me?
Thank you.
Yes, sir, I do.
Nice presentation. Thank you very, very much. I have two questions. One is, with the recent data that you can decrease death using the serum glucose transport 2 blockers, it goes down 15, 20% death. You know, I think that if one could overcome the economic barriers, but the barriers are the expense of these things, that we will see these things replace metformin. Because metformin doesn't have the same data in terms of preventing death, if you will. But I think that there's so much coming out in cardiology, not endocrine, it's cardiology data, in terms of the importance of this, you know, the serum glucose transporter 2 inhibitor, changing cardiovascular mortality, not blood sugars, et cetera, and so on, A1Cs and so forth. But it's amazing data. I think the field is being revolutionized to newer agents. The problem is their cost. But these new agents are so much better in terms of mortality. That's what's important. You know, that's question number one. Question number two is, what about the longer acting insulins, giving them once a week? I think that they are coming to the fore in terms of that type of use. But I appreciate your comments on those.
I will take the long-acting insulin. I forgot the name. I actually did read about it. However, the data, we don't have a lot of data for that. So when I was reading the detail about it, so therefore I excluded that from discussion. It is not very well widely still used in the United States. And although they're FDA approved, the weekly use. So that's my only short answer for the very long acting insulin. However, now the semaglutide, the GLP-1 agonist, these medicines are amazing, especially Ozempic or semaglutide is actually also FDA approved for weight loss, even in non-diabetic people. And the reason behind it, it mimics the gut hormone incretin. It mimics the normal, it doesn't mimic, but actually all it does, it sensitizes the GLP receptors. And GLP receptors are the one present in liver, pancreas, muscles, and what they do is sensitize the insulin and increase the insulin secretion. Interestingly, metformin also work to hypersensitize GLP receptors. So when metformin when GLP agonist was added with metformin, the studies show that they significantly increase the function of insulin. And patients on metformin with GLP, when GLP-1 agonist is added, shows dramatic increase in glucose control, as well as reduction in ASCVD. as well as weight loss, significant weight loss and metabolic syndrome. And weight loss, as we know by itself, it decreases all-cause mortality because we lose adipose tissue in leading to lipolysis and high LDLs. So they have multi-dimensional effects. And therefore, the picture I showed that I saw in one of the lectures years back, it's really incredible how the insulin malfunction, and then when we use these agents, improve insulin function, help with not only controlling blood sugar control, but right now in the field, we don't look at blood sugar control by itself. We're looking at all-cause mortality, because diabetes does mean all-cause mortality, because it affects a macrovascular and microvascular level, and such comprehensive effects that losing weight, controlling blood sugar, actually, it's a whole phenomenon now, and not only diabetes. So therefore, diabetes education plays a huge part in it. And again, repeating that blood sugar, when I was preparing for the lecture, it came to my understanding when like 15 years ago, when I was in school and residency, it was focused, we were focusing on controlling blood sugar and preventing complications. However, now this has become basically diabetes management is to reduce cardiovascular mortality. So I don't know if I answered your question.
One other question. This is a very difficult question. What is the advantage genetically of diabetes? Anybody have that? Well, what, it evolved. Why is diabetes there? Evolution is very complex.
Right.
Diabetes began really in the 18th century to be a problem and so on. Around the time of the Industrial Revolution, wasn't much of a problem until then, historically. But what is the advantage of diabetes? Can anybody name it?
The advantage?
There's an advantage. It's not just a disadvantaged disease. Larry, Dr. Falk, you know what it is? Larry, you're muted. I'm picking you, Larry, because you trained at Stanford. This is Stanford information.
Yeah, no, I racking my brain, Jim. I'm not sure.
Hey, do you remember Letterberg at Stanford, who was the Nobel Prize laureate?
Yeah.
Okay, he won the Nobel Prize at Stanford, and he was in infectious diseases. He gave a lecture on the advantage of diabetes mellitus, and it was intellect. You actually have higher IQ points per diabetes, has to do with birth weight, okay? But he gave a very complex lecture in terms of diabetes has the advantage of increased intellect. And this was his comment. It was very interesting. I think it had a lot to do with large babies as opposed to small babies. But I couldn't challenge him. He was the Nobel laureate lecturer, giving the description. But he said, "What is the advantage of diabetes?" And he said, "It is you're smarter."
Wow.
Think about that. All right.
I have to
The other advantage in civilization is a shorter life.
I wonder if we could get access to that lecture.
Well,
Probably not.
He's not around anymore, so I don't know. But
I
the
wonder-
lecture, maybe.
I wonder if it is somewhere.
And he had diabetes, by the way.
Okay.
I do see a raised hand. I think we have one more question. Is it Dr. Agogo?
Yeah, good evening. Oh, sorry, it's evening over here. This is Nigeria. I'm a pharmacist. I work with Federal Medical Center, Yenagua. Yeah, I actually followed this case, the very, very interesting presentation. Thank you so much, the presenter. But my worries is that all through his presentation, he did not say anything about the lifestyle modification. Because yeah, though I am a pharmacist, when they come to take their drugs, after we've administered, we also emphasize about their lifestyle. Many of them still eat very late. They have so many things that they eat to add up to their cholesterol level and all that. And even monitoring to some of the doing their tests on their own at home. We do all that, but I didn't hear anything about that in the presenter. So I just want to ask the presenter, is it that over there's no much emphasis on the lifestyle? Then also, I also noticed that some of the drugs they spoke about, some of them were so expensive and they were not covered under the insurance. And I am actually surprised because the same thing happens over here. We have a lot of drugs that are not covered, and then they end up to go and buy it outside. I know so many patients who are on insulin, and funny enough, initially it was covered and recently is not covered, and they buy it, and the burden to buy, economic situation here is very, very high, the burden of buying it, and that confirms why they don't comply sometimes to their medications. So I was surprised when I also saw that too over there too, that some of their drugs too are not covered and they are also expensive, and so they had to give him a kind of alternative. So the second one is just a kind of comment, but my question is about the lifestyle modification. Thank you.
I agree with you. In the third world countries, developing countries, it's a challenge. The challenge comes in many different ways. And let's talk about lifestyle modification, not eating right, weight gain. Actually, it's a problem in the United States as well. It's not a problem of developing countries, I would say. However, cost effectiveness is. But to tell you the truth, we also hear the same thing. Insurance, if doesn't cover, for example, let's say semaglutide. It's the oral form. When I actually checked yesterday, I think the 7 milligram once a day tablet for a 1 month supply was $900.
Yes.
Without insurance. And because when I was preparing for lecture, and when the recommendation says that we should use GLP-1 agonists because they are incredible, yes, they are, but if it is not covered, it is usually covered by most insurance, including Medicare and Medi-Cal, but there's either high copay, and if someone has no insurance, then absolutely, of course, they're not going to use it. So answering your question, yeah, in developing countries where insurance is usually not a, shall I say, a luxury or commodity, is not there, it's going to be a challenge. So we come down then to the cheaper options. Fortunately, we still have metformin, which is still a good agent. It is weight neutral plus or sometimes reduce weight as well. So all it comes down to my lifestyle modifications. That where the game change happens. So that's which is the game changer, and it all comes down to educating the person again and again and again. I also was reading that the diabetes education that we advise to schedule patient for a class after first diagnosis actually should be done at least 2 or 3 times at every visit, because the first class or first time a patient is educated, there's just so much into it because it's a complete change in the lifestyle. It's very difficult to digest, absorb, and put into practice. So what works is to keep repeating that. So have them have handouts like printed material. Tell them to hang on your kitchen. There are several things in color format. Now, internet has made it easy. You can go online, go American Diabetes Association guidelines, and you can see tons of material printed. We can print them out, gives handout to patients, and give them every time, repetitively. So repetition makes it easy for them to remember and put it into their life routine. And it still is going to be a challenge because not everyone can buy lots of vegetables, live on high protein, and live on fruits and not have starch. So it's a challenge, of course. I hope I answered your question, but I think
That's right. Yes, you did. Thank you. Thank you.
Okay.
All right, any last questions? It looks like we're wrapping up on our hour pretty soon.
Okay.
Thank you, Mohammed.
Yes,
Thank
thank
you.
you for the presentation, and thank you everyone for coming.
So I will schedule Natalie for, we'll have a next topic for a series of lectures, and I will talk to you about that.
Yes, you can go ahead and
Sure.
email me. Thank you everyone for coming and for your continued interest in Global Grand Rounds. You'll be able to get CME credit next on September 14th as we're moving to a monthly presentation. So please mark that date in your calendar. We'll of course send out the invite. Yeah, thank you guys and have a great day. I'll put my email in the chat box.
Thank you,
in case you have any
guys.
questions.